The session that we will be starting now is titled Building Resilient Communities. While I introduce the session, I'd like to invite our speakers, Elder Atum, Dr. Cyrus Batheja, and Dr. Katy Kozhimannil onto the stage, as well as our moderator. This session will be moderated by Ms. Andriana Abariotes, who co-directs the Interdisciplinary Research Leaders Program and is one of our foremost experts in place and people-based strategies to promote neighborhood wellness. Our speakers collectively hold a formidable wealth of knowledge and experience in many areas of community development. Their work on topics such as culturally centered community building, healthcare needs of rural communities, and integrated community care has been a real guiding beacon of light for research in this area. Please join me in welcoming our new panel.
Thank you, Kumi, and thank you, Dean Finnegan, for inviting me to help moderate this session. It's filled with some of my favorite people and our esteemed colleagues in this work. So I'm really excited to be here. As Kumi mentioned, I'm Andriana Abariotes, and I came back to the university about a year ago to help co-direct the Interdisciplinary Research Leaders Program, which is one of 4 of the Robert Wood Johnson Foundation's national leadership programs, which the School of Public Health is hosting for the country. And it's really exciting to be back on campus, to be pursuing community-engaged, action-oriented research to promote health and wellness. This is coming after many, many years doing work in communities, both neighborhoods and suburban communities throughout the region here as a community development investment organization. So I am just really excited to move from what we were talking about and listening to with Marion and Dan this morning about some of these broader brush issues that are impacting our communities to get down into some more detail about how that plays out. And so you're going to be hearing from a panel of 3 experts who are going to bring very different but complementary perspectives on what it means to be building resilient communities. I'm going to give just a quick overview of each of our panelists. They're going to each present their perspectives and insights, and then we'll be engaging in a little bit of dialogue here as a panel, and then hopefully with all of you, and conclude somewhat on time, maybe making up a little bit of time before lunch. So thank you. Our first panelist is going to be Cyrus Batheja. He is the Chief Growth Officer for myConnections and the Medicaid Vice President at UnitedHealthCare. And myConnections is UnitedHealthCare's program that helps low-income individuals and families access essential social services that are the gateway to better health. In addition to focusing on serving special populations, his work is centered on achieving the triple aim: cost reduction, population health improvement, enhanced patient and provider experiences, and has over 21 years of experience in managed care and Medicaid, home and community-based services. Plus, he has a series of degrees. I was getting exhausted just looking at it. It was a doctorate, a nursing degree, an MBA, so he is well-versed in many ways in which we can tackle some of these issues. And he has certainly been recognized for his leadership, receiving the Minneapolis-St. Paul Magazine 2013 Award in Administrative Nursing Leadership, the Atum Hero Award, and he's a 2012 March of Dimes Nurse of the Year. But most importantly, he wanted me to share that he and his wife are adult foster care providers, and that's one of the places he gets the most joy. So welcome, Cyrus. Next, we'll have Dr. Katy Kozhimannil, who's Associate Professor at the Division of Health Policy and Management here at the University of Minnesota School of Public Health. She's also the Director of Research for the Rural Health Research Center. Dr. Kozhimannil conducts research to inform the development, implementation, and evaluation of health policy that impacts healthcare delivery, quality, and outcomes during critical times in the life course, including pregnancy and childbirth. The goal of her scholarly work is to contribute to the evidence base for clinical and policy strategies to advance racial, gender, and geographic equity, addressing social determinants and social and structural injustice to improve health and well-being. She has numerous research grants, publications, and awards. The list was very long. I'm just check it out. She's got a lot of great work. But one of those awards was actually being one of the first fellows in the Interdisciplinary Research Leaders program, where I had the honor of helping support her in that work, working with Dr. Rachel Hardiman and Rebecca Polston, who is the founder of Roots Community Birth Center, Minnesota's first and only African-American owned birth center, to document the process and outcomes of culturally centered model of care and to work towards equity and birth outcomes in Minnesota and beyond. Last but not least is Elder Atum Azzahir. She is the president and executive director for the Cultural Wellness Center. She has been a long, steady and scholar in promoting African thought and spirituality. And many of you may know her. She has developed and managed organizations, written and produced other materials on the African intellectual heritage. The institutions she has founded have created community models for workforce redevelopment, entrepreneurship, mediation practices in order for the African in America to interface with mainstream communities. People who have studied with Elder Atum are in key leadership positions across the country and in various institutions, and many have consistently come back and returned for coaching and connecting with her over 23 years. She has founded and co-founded numerous initiatives and organizations, including the Cultural Wellness Center and the Backyard Initiative in South Minneapolis, where I had the privilege of serving with her in that work. That was a tremendous opportunity. I hope we'll get into more detail there. Just a word of a couple of assumptions as we kind of start into our work here. We kind of assumed that we wouldn't need to go deep into definition of social determinants to this audience of public health researchers and practitioners. But we did think that we find ourselves not always sharing a definition of what community may mean. And so as we think about talking about communities that may be geographic, it may be communities of culture and identity, it may be special patient populations. And so that's just one of the things that we wanted to lift up as we talk about what resilient communities mean. We also know that doing cross-sector work and collaboration is difficult. We heard from Commissioner Malcolm this morning, kind of really challenging us to be thinking about how to do that. But as we know, systems are complex and fragmented, and oftentimes reinforcing many of the structural inequities that we continue to face. And so we need to challenge ourselves in those areas. And that, lastly, that individuals and communities are taking it upon themselves to define what health and well-being means. And as researchers and practitioners in the public health and medical care fields, we really need to push ourselves further out of the way we may have always done business to really drive towards that more collaborative, integrative way of doing business. So with that, I'm going to turn it over to Cyrus, who's going to kick us off this morning.
Good morning, everyone. Thank you, Andriana. Thank you for having me today. I'm honored to be part of this panel and with the other esteemed colleagues here on the panel. Today, I'm going to bring you through my definition of community and talk to you a little bit about my personal story to start. I like to do that because I think that we lose sight of that within the system in which we live. We are in a place of really focusing on individual needs, wants, and desires, and forgetting about the collective action that we have the opportunity to be able to pursue. From there, I'm going to take you through a little bit of our work and some of my learnings as I have been able to understand the United States and more broadly global trends within population health and where we can really make an impact as we think about the people that we serve. I, as Andriana had mentioned, have a background in nursing and in public health as well. And I'm very focused here locally in the Twin Cities in being an adult foster care provider. I think it's an important point. It's basically something that my wife and I got involved in about 20 years ago. It involves us opening our home to people with special needs. My wife and I have particularly focused on individuals who are transitioning out of their family living setting and moving into life on their own. And thinking about sharing all that we have, so opening our home, and now sharing our children, our pets, our food, our transportation, thinking about things in a more collective versus individualistic manner. And as I take you through my own journey, and that's where I'll start, you'll understand my life mission and vision and why, of all the things that my family and I have been able to accomplish since coming to the United States in 1985, that is one of the most important, or if not the most important accomplishment to me, of being able to share what we have collectively with the community and building that resilience as one with the community rather than set aside. So I've shared with the group today some personal pictures to take you through my journey and explain to you where I've come from and where we are now. So starting, I'd like to take you to the middle picture. So this is a motel. You all might be familiar with it. It's in South Minneapolis. It's off Lyndale Avenue. It's called the Boulevard Motel. That is where my family and I landed when we came from London, England. My folks are two-time immigrants. They first moved from India to England, and then again lived there for 18 years and moved from England to the United States to Minneapolis. The Boulevard Motel is important to me because it's where I started to learn about Minneapolis community, and it's also the place where I learned that people aren't always looking at the importance of collective action and support, but rather individualistic goals. And I say that because when we came to the Boulevard Motel, we came with really great hopes of being able to thrive as a family here in the Twin Cities, and unfortunately fell on hard times due to our immigration status. We came on a business visa and were exploited in the hotel. So my mom worked in that hotel for a number of years for pennies on the dollar, cleaning hotel rooms. She was trained as an accountant in India and in England, but was really forced into that work because of the situation that our family found ourselves in. Eventually, and I've got a picture there of me in England in private school in 1983. And then another picture underneath of me in the Minneapolis school system, and that was the community in which I knew at the time. The picture right above the Boulevard Motel is a picture of my mom graduating from nursing school. So I said I'm a registered nurse. It's important to understand that I found my path and I found community in nursing through my mom. So my mom went to Normandale Community College. That was the path in which she took to be able to establish ourselves, to find our way to permanent citizenship, and really to be able to then start to, what I feel, give back to the community, become adult foster care providers. Moving to the right, once that happened, and once we were able to find ourselves a place within the broader community, we were able to really start to give back in a lot of different ways. So, as I said, my mom went to Normandale Community College. I went there with her for many days as a little guy growing up, and ended up going through the same nursing program that she went through. A lot of the professors remembered me as the little guy who used to accompany my mom in her nursing classes. The part of the story that I didn't tell is that through the immigration process, and then my mom eventually finding her way to nursing school, my parents ended up divorcing. And I really accredit that to the hard times and the challenges that we faced through immigration, through the exploitation, and really through the marginalization of our family. So moving beyond that, as I went through nursing school and found my place in community, we were able to start thinking about ways to give back, and I really was committed at that point, mission-driven, to help to build resilient, supportive communities. And I knew that the way to do that was through collective action, through bringing together organizations that were vetted and really knew the community and were integrated well. And so if we look to the right side of the picture, you can see here that not only am I dedicated to this, but I've been lucky enough to have a family who's very supportive of this vision and mission as well. And so you can see there on the bottom a picture of my wife and my two kiddos, who, again, like I said, we're living this vision through the work. And then there's some other pictures of me continuing to move forward and my family continuing to give back in different ways. So I share this brief snapshot of my story to, one, give you the understanding that personal narrative has a really important place in building resilient communities. I think that as I have looked at healthcare across the United States, what I've come to find is it's highly transactional. It's about checking boxes and doing different types of assessments, and we lose the opportunity to share story, to understand people's personal narrative. I've been fortunate enough to understand global health systems and look at places that are really doing a good job at delivering high quality health care. And the thing that I've extracted from it is twofold. One, keep it simple. And two, coffee and conversation. Taking time to really get to know people and understand where they're coming from can make the greatest difference. A greater difference in some cases than even checking vital signs. And so, those aspects, if anything, I leave you with here today, are, I think, the most important. It's okay to share your story and have a little bit of vulnerability. And two, it's okay to understand other people's story and then understand the interconnections. To me, that is the essence of community and being able to support one another. So, now into, I think, the meatier topics, perhaps, or giving you some tangible learnings. So, a collective impact model. So this is something that I've started to develop. I work at UnitedHealth Group, UnitedHealthCare in their Medicaid department. Spent now a decade there as an offshoot of the work we were doing here in Minneapolis. Was lucky enough to get connected with them. In thinking about some of the most vulnerable populations within our portfolio, we serve about 7 million Medicaid recipients around 30 states in the United States. And what I've done in that role is been able to use our robust set of data to understand the most vulnerable and challenged populations, particularly populations of people experiencing homelessness, people experiencing addiction, recent release from incarceration, aging out of foster care, and then looking at population health trends within that group. So what we were able to do, and we've looked at the trends and we saw that this population, and you may have heard this statistic, this population of roughly the top 5%, we're spending in line of 50% of the total Medicaid dollars. And so the solutions that we started to come up with really involved partnering with high fidelity partners in the communities where we had hotspots, large numbers of these folks collecting in single sites, and then supporting those individuals through resources that were already in the community but were not well orchestrated. So looking at the aligned efforts and connecting those organizations with evidence-based approaches, accelerating the access and use of data. So we control a lot of health-based data. They were very interested in that and had social data a lot of times that we didn't have access to. So things like incorporation of homelessness data through things like the Homelessness Management Information System, incarceration data, food data through SNAP, the bringing together of data in community data toolboxes around the country to be able to understand people in a more holistic way. Also, looking at things through what I call a socio-clinical lens. So we have really medicalized individuals, and I go back to the idea and power of narrative. Understanding people's social situation has a far greater impact than their medical situation. But when you connect the two, the power is pretty significant. So starting with understanding of people's social data and then connecting that with their medical and nursing needs was the approach that we really took on, and then advocating through our learned experiences to the government and to associated partners on the continued growth and development of this type of model. This is an example of that. So this is a hotspotting example on the right. This is where we've been able to use ICD-10 codes, particularly the Z59.0 homelessness code that we can pick up. I found about 25,000 of these codes within our 7 million. And was able to, this is actually a map of the Las Vegas area where we have a housing health strategy that uses housing first and trauma-informed care to bring together data sets across schools and universities, jails, healthcare organizations, social service agencies, even financial institutions and transportation providers as well. So coming together with all of the data and then starting to collaborate with these high-fidelity partners to create a collective impact model where each partner was able to do their best work and at the same time synergistically create a model that was supportive of the community more broadly and created a deeper understanding, frankly, of that community and some of the most vulnerable patients, most vulnerable people in the community, and taking time to understand the stories of those individuals. So looking at it from this quantitative standpoint, but then also looking at it from a qualitative standpoint, the personal journeys of these individuals, moving from a paradigm of what's wrong with you to what happened to you was the way that we really positioned this work. And so as we position that work, we also developed a new care philosophy within our organization. We've scaled it to now about 5,000 providers around the United States. It involved aspects of trauma-informed care, adverse childhood experiences, positive psychology, motivational interviewing, understanding people's personal goals to help them to achieve rather than instilling our goals, and really keeping a focus on person-centered well-being. We created a collective language. So really looking at the use of these ICD-10 social determinant of health codes and creating easy to use tools for providers to be able to understand the value proposition in doing that work. So being able to really get tight on what the needs, wants, and desires of people are, and then being able to speak to that in a variety of different ways. So ultimately, looking to achieve the quadruple aim and making sure that, I'll just leave you with this idea. Providers in the situations that I have had the opportunity to engage are dissatisfied when they are medicalizing cases. They are dissatisfied because there's a lot of social needs that they feel under-equipped to be able to meet. So although they can maybe identify those folks, they don't know what to do. They don't know what to do when somebody walks into their office and says, hey, I'm struggling with homelessness, outside of making a referral to a social worker. So by creating the right socio-clinical pathways for these individuals that uses that collective impact network that's been created, it really is able to help these people to feel like they're achieving more than just what they've traditionally been able to do, which is, diagnose and prescribe, but making a meaningful difference in the lives of the people that they serve. So through that, we represent this work in forums like this, not only here in the U.S., but around the world. and are thinking about how do we continue to make this social movement a reality of taking people's personal narratives and putting that at the center of care rather than putting the medical kind of needs that we've been taught traditionally in programs at the center. And so, one person at a time is key to the success that we've been able to achieve. So with that, Andriana, I'll turn it back to you. Yeah.
So today I am here to be accountable for myself and my community of public health professionals to the communities that we all belong to. Community is not out there, it is in here. It is in all of us, and integrating ourselves into the work that we do, those of us that have power and privilege to be able to shape the health of communities, is the only way that we're going to move forward in the right way. Speaking of which, I would like to start my remarks today by gratefully acknowledging the Wapakote, Anishinaabe, and Osheri-Sakoan Dakota people on whose traditional ancestral lands we're gathered today. And I want to acknowledge the importance of Indigenous knowledge for taking us forward. I'm also going to speak about some research that I've done, and I want to acknowledge with gratitude my funders at the Federal Office of Rural Health Policy. I want to start with the concept that we hear a lot in pop culture right now. And I'm going to argue that we need to face head-on how we as public health communities have taken ourselves, or as public health professionals have taken, researchers have taken ourselves out of the picture and seen community as out there and ourselves as here. And I think that to support public health in communities, we need to stop gaslighting and start empowering communities. How many of you have heard of what gaslighting is? Could you raise your hand? Okay, we know, good. So these definitional pieces may not be necessary, but just so that we're all on the same page. Gaslighting refers to the act of undermining another person's reality by denying facts, feelings, and their environment. And this term comes from 1938 stage play where there was an abusive husband who was dimming the lights that were gas lamps in the home and denying that that was happening, to the point where his wife, it broke down her ability to trust her own perceptions. He was shaping a reality that wasn't what she was living. We would never do that in public health, would we? We would never do that. In my work in maternal morbidity and mortality, we see this all the time, and we see structural inequities in how people's reality is denied by professionals who believe that they're doing the right thing and are so uncomfortable with the fact that they may be doing this. They're so unaware that they can't grapple with their own role in producing the inequities that we see, the pernicious, horrible, unspeakable inequities that we see in, for example, maternal morbidity and mortality, infant morbidity and mortality, where we have rates that are double or triple for Black and Indigenous folks in this country and in this state here in Minnesota. So how does gaslighting look? Here are some phrases that are commonly used in gaslighting. You're just paranoid, you're making that up, it's not a big deal, you're being dramatic, you're getting worked up, that never happened. These are variations of these can come with the way that public health as a field has interacted in community. And I think it's time that we reckon with the consequences of that way of interacting. How do we do better? We do better by listening, by learning, and by giving up space, resources, and opportunities so that others might experience their full potential. And this is what empowerment is. And I'm not talking about me or any of us empowering anyone else. I'm talking about the steps that we can take to allow people to step into their own power. Empowerment is the state of being empowered to do something. The power, the right, the authority to do something. In our work, do we take that away from the folks that we work with? Do we take that away from ourselves as individuals if we disentangle ourselves or de-identify from our communities in the work that we do? Isn't this what communities really need? Isn't it what all of us really need? I believe that the public health focus on individual behaviors and diagnoses and disease codes, it can be gaslighting because it does not address the social determinants of health or the structural inequities that shape social determinants of health, that precede and create the social determinants of health. I see this all the time in maternal mortality discussions, where there's an emphasis on hypertension, obesity, nutrition, physical activity, all of these, attending prenatal care visits. And it creates a mother blame narrative that blames Black and Indigenous women for their own deaths. It's unacceptable. Yes, those are proximal causes. But there are predisposing factors that precede that, and there are social determinants that precede that, and there are systems and structures and policies in place that shape how we get there. If we focus on individual behaviors, we are gaslighting the communities that we belong to and the communities that we intend to serve and work with. I would argue that even our discussion of social determinants of health sometimes has tinges of this individual level risk that doesn't fully recognize structural inequities. We need to not be afraid to talk about racism. We need to say that word, and we also need to recognize our part in it. Can we focus on structural inequities based on geography, gender, age, ability, race, to enhance the vitality of communities? How do we do this? How do we do better in public health? I believe that we can. I have a lot of hope about this for myself and for all of you. And I will say, I am learning in this process, and I invite you to learn with me. I want to stop here for a moment and also say that this is important to me, not just as a researcher or a faculty member in the School of Public Health, but as a person in terms of who I am. And I want to draw on Cyrus's point about personal narrative to say that I am a descendant of the White Earth Band of Ojibwe. I am a mother. I am a daughter. I am a sister. I am a neighbor. Those are pieces of who I am that inform the questions that I ask, and I shouldn't sanitize my identity from the questions that I ask, or they're going to be the wrong questions. We need to bring our full selves to the work that we do in public health in order to fully serve the communities that we belong to and to learn how to listen to those communities we don't belong to. We can start by listening to the wisdom of communities, and that is what will get us towards shared power. Shared power is defined here as the strong strategic, long-term, and trusting relationships with community partners that are vital to advancing health equity. There are a number of, I'm not going to give you a lot of tools here today, but I do want to give you one that I think is it's been so foundational to me, to my thinking, and it's something that I keep coming back to. And that is the Equity Manifesto from PolicyLink. It begins by joining together, by believing in the potency of inclusion and building from a common bond. It starts with our humanity and our stories and binding ourselves together to one another, so much that we feel the pain of communities that we do not belong to, but we understand that through our shared humanity and our connection, our future is inextricably bound up together. Here are a few concrete steps that I think that we can take. I think we need to stop calling resilient communities vulnerable and start recognizing the strengths that everyone brings based on their culture, their history, their background. People that have experienced ACEs may have, adverse childhood events, may have greater vulnerability to certain health outcomes. We know that's true. We have a lot of research that says this. They have also experienced extraordinary strength, and the value of those experiences should not be diminished while we focus on the pain and the healing that needs to occur. Secondly, we need to recognize our own power in whatever access we have that power, and we need to give it away to those that do not have it. This is a very hard part of this work, but giving away our own power and sharing it is essential. We need to ensure representation by community. We need to ensure the voices of the people that are most deeply affected by the issues and topics that we care about are not just at the table, but are leading the discussion and making the decisions. Fourth, we need to place resource control within communities. Let the decisions be made by those that are the most affected. And finally, we need to center at the margins. And by this, I mean redefining what normal is. Sometimes I think of this so frequently whenever you read a news article and it talks about, a woman engineer at Google said this or that. Why did there need to be a qualifier of woman there? Because we assumed it was a man. We were norming, we were centering around that idea. A black engineer at Google said this. If we just say a Google engineer, there's an assumption there's an identity assumption about that. It's so frequent, it's so pernicious, it's so hard to see unless you are othered by it, and then you see it very clearly. So I would encourage us to think about what we call normal and what we are norming around. I want to take a few minutes to provide an example from my own research of my own learning in this space and what an honor it has been for me when my own work has been led by community-based questions. This example comes from the University of Minnesota Rural Health Research Center, where we conduct policy-relevant research to improve the lives of rural residents and families, advance health equity, and enhance the vitality of rural communities. I want to tell you a story about some families in Alabama, in rural Alabama. So there are 18 million reproductive age women that live in the rural United States, and 500,000 babies born in the rural USA every year. We know, research has shown that there's been declining access to obstetric care in rural communities. This is something that's not just happening in the United States, it happens worldwide. But in 2016, a group of 3 grandmothers in rural Alabama went to their congresswoman. So these were black grannies in the rural South, and they know what's what. And they went to their congresswoman, Terry Sewell, who also happened to be a black woman, and they said to her, the hospitals around us are closing their maternity units, and our moms don't have a place to go to give birth. They have to travel really far. This is a problem. Is this just happening here, or is it happening all over the place? What's going on? And Representative Sewell called the National Rural Health Association, and she asked them, is this just happening in my district, in my congressional district, or is this happening all over the place? And the National Rural Health Association called me because I had been doing rural maternity research for the past 4 years. And they asked me that question, and I said, we don't know, but I know how to answer it, and that's a good question. But my funding had already been set for the year, my projects had been decided, and we didn't have, there wasn't a clear path forward to immediately start doing that work because resources matter, right? The National Rural Health Association called the Federal Office of Rural Health Policy and asked them if it would be possible to change the topic of our study, and it was, and they did. And we were immediately able, with a fantastic team here, to start analyzing data to look at this question of rural obstetric unit closures and which communities were the most affected. So I have just a couple minutes left. There are a lot of reasons that rural hospitals close: financial constraints, you don't have enough clinicians to take care of needs, patient safety concerns when your numbers of patients get really low. And the question that we were asking, given the data we were able to get, was from 2004 to 2014, how many rural communities lost hospital-based obstetric services, and what were the characteristics of those communities? What you can see here is that the rural counties with hospital-based obstetric services declined over time. This map shows a county-based map of our analysis. I'm not getting into the details of this. If you want to read the papers or talk with me about nerdy methods, I am here for that. So, but what I want to do is come back to the consequences. Our key findings were that Between 2004 and 2014, 9% of all rural counties lost hospital-based obstetric services. That means the hospital closed entirely or it stopped doing deliveries. By 2014, more than half of all rural counties had no place where you could give birth. No one had done this study before, no one knew that. What was interesting as well is that we found that the communities with fewer primary care providers, the communities with lower incomes, those communities were more likely to lose hospital-based obstetric services. That wasn't surprising. Communities, rural counties that were in states with less generous Medicaid programs were more likely to lose hospital-based obstetric services. That also stands to reason. One finding really stood out. Rural communities with a higher proportion of reproductive age women who were Black, controlling for everything else, were more likely to lose hospital-based obstetric services. Those women in Alabama were exactly right. Their communities were being disproportionately affected. We also did some research looking at the consequences of those closures, and what we found is that the most remote rural communities that lost hospital-based obstetric services had an increase in preterm birth. Preterm birth is already 4 times higher among Black infants than among white infants, and it's the leading cause of infant mortality. So the consequences are real in terms of lives lost. We published this paper in a very high impact journal. We did a congressional briefing on the Improving Access to Maternity Care Act on International Women's Day of 2018. This act was signed into law in December of 2018. It was just over 2 years after these, the Alabama grannies started asking these questions. The Improving Access to Maternity Care Act designates maternity care shortage areas and extends some federal resources to support that. So it may actually be able to make a difference in the lives of these people and communities. This was possible because 3 Alabama grannies asked a really good question. They asked exactly the right question, and I had the honor of being able to have the skills and the resources to answer that question, to help them get an answer to their very good question. It's some of the most impactful research that I have ever done, and I am so deeply grateful to have had a chance to investigate in this way, and it is my hope that moving forward, that in the work that I am able to do and in the work that we are able to do as a field, that this type of integration will help us move toward greater equity and toward the types of communities that we all want to live in and be a part of. Thank you so much for your time today.
I think I'm going to start by acknowledging that I had a PowerPoint, which I don't normally have. But after I read through who's on the panel with me, and I looked at who the quote-unquote 400 people are who might be here today, I said, I need a PowerPoint. So guess what happened? 2 days we spent doing a PowerPoint. And I get here this morning, bless Akmiri's soul, I don't have the PowerPoint. So it was intended to be this way, yes? That I do not have a PowerPoint. I also want to acknowledge that 75 years is what we're celebrating for the School of Public Health, is that right? Guess what? I'm 75 years old. And I think, Dean Finnegan, if you're here, you knew that. So this whole idea of my relationship, our relationship, Dean Finnegan back there knew she's 75, so we're going to take that 75 and put it to the School of Public Health. But we've been doing it for 150 years, yes? Same here. So if I appear tired, that's why. But I also want to acknowledge how many public health students that I embraced since getting here this morning who have been studying at the Cultural Wellness Center. The Cultural Wellness Center has taught and learned from over 800 public health students who have come to study at the Cultural Wellness Center, 20 to 25 students every year since 1995. You have to give a round of applause. The faculty in the School of Public Health, the Department of Medicine, Epidemiology, I can go on, have brought students, and the students who have worked with us have given us amazing stories about what happened as they began to think about the difference between academic knowledge, institutional and academic knowledge, and cultural knowledge. One of the major exercises done with our students is, who are you and who are your people? Is there a public health student in the room who've come to take our classes? Please raise your hand. I see, you gotta raise it high because I can see you. Did you get the exercise? Who are you and who are your people? Yes. As today, 95% of the students who have come are of European heritage. In many, many, many cases, this was the first time anyone had posed that question as a source of study, not just about what's happening to other people, but what is happening to you. What is both happening to you? What is it that you are walking around with? Who is that person inside of you who is dying to get out in your classroom? Who is that person who is really asking the questions of yourself when you look in the mirror in the morning? So students who have come, and again, I mean this is an estimate of 800. That's Dr. Sarah Axtell, Dr. Craig Hassel, many of the ones, Kathleen Call and others who have worked with us, struggled with us. The struggle for us has been not just what is knowledge, but what is research. We have over and over again stated that what is happening with cultural communities and the way that what is happening is described is in itself a problem. That the research, the language, all of the ways that people are studied and talked about and presented and represented is really a part of the problem that we're facing. So we have invited the School of Public Health, the Department of Medicine here at the university, to rethink the question about research. What is research? We've concluded ourselves as we have studied ourselves, our being, people of African heritage to whom I owe my existence. What I said to ourselves, on earth are we doing, walking around like we are nobody, we have nobody, we are nothing, begging for freedom, begging for someone to let us be who we are. I say to myself and others for this last 50 years, why am I asking that question of someone else? It isn't someone else who can answer it. And so I began to, with a lot of help from the people who came before me, say, this is who I am. And this knowledge about who I am, this understanding that who I am is indeed knowledge, is what we will found our work around research on. That is the basis on which we have founded research. And in our searching, we've also identified the problem that we must be involved in solving, no matter where we are and when we are there. The problem that we have really identified and articulated. I wish I had my PowerPoint so you could see this amazing picture. But many of you have seen it. It's called the People's Theory. You've been with us, you've seen this. The People's Theory says that individualism, loss of culture, and loss of community makes you sick. Individualism, loss of culture, loss of community makes you sick. We also, in our searching, saw that this downward process, which began with, in my study, people of African heritage in particular, this downward spiraling process began with, our community told me not to put on all these clothes. But it began with this downward spiraling process of being disconnected from language, peoplehood, from the activities that gave us capacity to stand what is now being referred to and studied as resiliency. What we knew is that we had to get up, we had to make ourselves better, we had to do better because no one else was going to do it for us. We had to look at all of the forces that were holding us down, denying that we were human beings. We couldn't go to that same force and say, make me free. You can't, that doesn't make sense, right? So all of that is where the Cultural Wellness Center came from. And again, it is where we owe what we now call research and knowledge. So this People's Theory came into existence after interviewing, studying, sitting with, listening to over 1,000 people in the South Minneapolis area. Many to this day continue after 23 years being teachers and faculty and elders at the Cultural Wellness Center. So this downward spiraling process of losing peoplehood, of losing connections, of losing what was for us a sacred experience of social support, losing all of that, put us on a path downward to where we now are known by the sickness, the disease, the crime, the violence that is visible in our places where we reside. Those places had come to not community, but they had become isolated, as you know, ghetto areas, and we continue to this day to struggle with. How do we de-ghettoize the places where we live? How do we decriminalize the acts that we take, the actions that we take in response to what our experiences are? We as in people of African heritage in particular, we must get up, stand up, and speak what is happening to us from the point of view of research and knowledge. So our cultural ways of knowing, become first those resources that we will use. They become our cultural capital to build relationships, to build ways of being, to build ways of becoming in such a way that we can actually live next door to someone who will not be afraid that we moved in. It's us. It's our beingness that we have studied, articulated, and turned into curriculum that many, many, many of the School of Public Health students are coming to us to learn, and for that we are grateful. We have identified this all and called it, and then began to study it as systems of thought. The African system of thought that for us begins with spirituality. Spirituality, symbol, mythos, and harmonium are the words that best describe what it is we refer to as our system of thought. We studied our system of thought, and then we named and studied the European system of thought, because it is a European system of thought that we fight versus putting it in the language of racism or white supremacy. Because as far as we're concerned, no one has benefited from being white. No one has either benefited from reacting to that. So ours are systems of thought. We compete, we write, we talk about, and we position ourselves in challenging the way of thinking that produced this condition that we all are suffering from in this society. I am not here to talk about my suffering. We are here to say that we are all suffering. And the School of Public Health has given us an opportunity to think about what will the future be if we all are fighting the internal suffering that we're doing and beginning to look at each other as a resource for what have you done to survive? What have you done to thrive? What have you done to be able to stand here in spite of all that has happened to you and your people over the last, in this country, 500 years? The study is about thought. Our major findings is that research is largely about finding language to articulate problems and to structure the way you think about yourself. So that's what we are doing. Our positive shift then has been that research and evaluation is the ground on which the Cultural Wellness Center has been able to stand. We would not be able to stand as long as with much potency without students from the university who come and value a knowledge system, a knowledge base, a knowledge process, a learning process, a method of teaching. It is the students from the university who come to talk to us about methods of teaching, who talk to us about this theme that Du Bois talked about, which is that a people, as in people of African heritage, who has been so handicapped not to be thought of as having language, knowledge systems, peoplehood, a condition that is aligned with the Creator. Do you know what I'm saying? That is what the perception is. So Du Bois wanted to know, a people thus handicapped ought not to be asked to race with the world, but rather allowed to give all of its time and thought to its own social problems. That doesn't mean that we go back to the system of not being integrated with you, not being able to work alongside of you. It doesn't mean that we're going to go off by ourselves and go inside of a hole, but we have to be together, visibly learning, visibly teaching, visibly being. There is one of the German scholars who talked about being. There is an absence of being, an absence of empathy that has really become pervasive in the university academic system. And it is on us to really work hard to try to replace that, because it's that very system of thought that has produced and enslaved many people. And at this point in time, no one wants to continue to be enslaved or enslaving. That's not what we want. You don't want it. We certainly don't want it. But we have to work together to eliminate it. It's going to come from thinking. It's going to come from how come you think that way about humanity. And we're going to ask over and over again, what is the current knowledge that we use, the language that we use, to really get at this whole idea, for example, of that public health in the past has used that talks about African Americans are experiencing disparity. In this word disparity is an emotional association with the word despair. Yes? So what we're told is that in this despair, research means that we are being reminded of the despair. So when the Cultural Wellness Center began to look at infant mortality, we did not look at quote-unquote infant mortality. We looked at babies who lived in spite of the conditions. My children, my son who is 60 today, who, this is not his birthday, but who is 60 now, is the one who told me to follow Dan Buettner because I'm 75 and he predicts I'm going to live to 90 based on the research that Dan has done. So do you know I was sitting over there texting my son saying, guess who I'm hearing this morning? And guess what he says is that I am going to live to 90. Because I didn't even raise my hand on all of the things because most of them, if I do them unconsciously. But what I do know is that there is something about how I felt this morning when I got up. There is something about the way I feel when the public health students greet us and say we are so happy to be here. There's something about the fact that I was with Alina as a partner for 25 years, and then most recently 10 to develop a very innovative system called the Backyard Initiative. And the woman who is holding that card up back there is one of my students. So what I want to say is that the Backyard Initiative really and truly epitomizes a lot of what I've just told you. The knowledge we use for research is based in culture and cultural ways of knowing. The research proved that social networks, all of the things that we're talking about now, that connectedness, they have, the Backyard Initiative has affirmed that every single one of those things that's within our culture has to now the power of connectedness, the power of relationships, the power of knowledge and creativity. We have, through our work together with the Alina Health System, put those things not only in place as a program and activities that happens at the Midtown Global Market. This community health hub, the Backyard Initiative, is now the community health hub. Do you know how 450 participants who worked with us to do this research found that social support was 93% of the 450 people responded that social support increases their health, their sense of health and well-being, that social cohesion increases their sense of belonging, that health education not just includes health education as do I tell my doctor what's wrong and what I want to do, but health education as in a different definition of health, which really is about not sickness and disease, but who am I? Who are my people? What are the connections that I have? What do I believe? What opportunities do I have? Health empowerment is also not about, do I know all the medical terms? Health empowerment is about when I come in, do you have the capacity for empathy, whether I can speak the language or not? Health empowerment is that I can sit before you, reach you, connect with you, and be who I am without looking at the watch and thinking my 10 or 12 minutes are going to be up. What we have found with the public health students, what we have found with medical students, what we have found with the residency programs that come through the Cultural Wellness Center is people leave with that capacity to connect with, to know with, and to be with people no matter where they come from, when they arrived here, what their particular cultural or racial identity is that they're working through. That's what we get. I want to conclude by saying that my sons, my grandchildren, my husband have really given me the capacity to believe again in this society. And as we talked, as I said earlier, many of the people, including Dean Finnegan, the CEO at Aligner, J.M. Malcolm, and others, have also come to know not just me, but my children and the work that they do to contribute to the future of not just public health, but health generally, population health. My husband really and truly is the most brilliant scholar in the world. His work on Kemet or Egyptology is very, very well known across the country among and within Black people's study of ourselves, reconstructing of our own ways of knowing and being. And for that, once again, I can give deep gratitude this morning, and to you for being present here today and for allowing me to be a part of this. And I say that in quotes because most people know that no one allows me to do anything, but I do appreciate very much the fact that you are sitting, and you're doing the work that you're doing. Thank you to the School of Public Health and the 800 students that have been with us for the last 25 years. Thank you.
Thank you. I know we're kind of coming up short on time, but I think we did want to have a couple of chances to dialogue about all of the information that was presented here. You can see some very compelling and meaningful ways of thinking about community at multiple different levels. And so just very, again, honored and appreciative of our panelists this morning. One of the things that I was really struck on, and I think oftentimes we come into a concept of building resilient communities, we immediately think to the word building, and then communities being a very place-based kind of construct. And this morning, one of my personal history at the Backyard Initiative was as a community development investor in the neighborhood, to which in South Minneapolis, I think we had invested about $180 million over 20 years. And then we started having a conversation about health, which I find really, really striking. And so as we think about all of the ways we have levers and policy and tools and resources to work across multiple sectors, multiple industries, putting people, putting narrative, putting connection, which you all were touching upon this morning, I think is really kind of at the foundation of how we begin to kind of build and reinforce resiliency in communities. So thank you. A question to kind of get us started, and then we'll open it up for a few questions from the audience. We talked a lot about assets and strengths as a way of switching from the paradigm of focusing on disease and despair or disparities. What should we be talking about as a public health field around really leveraging more around assets, or leveraging more around strengths, changing how we are defining some of the work? And who would like to start?
Thank you, Andriana, for that question. I think about this a lot as a researcher in rural health. We had a press briefing yesterday in Washington, D.C. on an issue of the journal Health Affairs that was entirely focused on rural health. And so many of the pieces of research, right, were looking at decrements, and that created the narrative around rural health being this, horrible wasteland where you would never want to be and you can't get anything you want, and all of these types of challenges. And that can be true. So decrements can be true alongside of strengths, and both are important. And it's important to think about from a technical research perspective, or from a programmatic perspective, what are we measuring, what are our outcomes? Can we look at the positive things and try to create more of that, or to honor that, as opposed to always looking at the negative things? And I also appreciate the way that you conducted research on infant survival, and as opposed to infant mortality, and focusing on the resilience and the positivity and the flourishing of so many of our babies, in spite of and held alongside of the challenges that are faced. And so I think that there's a lot that we can do from a technical perspective with regard to measurement and outcomes and how we think about them. Also allowing folks in community to define for themselves what's important, and then measuring that thing, the important thing, the good thing, the thing we want more of.
You know, I think, once again, the challenge for the Cultural Wellness Center and for our way of thinking about knowledge now, and language in particular, that even the language used to talk about assets and all of those, we really want to, that's not how we talk about ourselves. I don't talk about my strengths. You know, it's what the man earlier said about he forgot to die. Well, we also, it's natural to have a healthy baby. It isn't unnatural. It's not a medical condition. So what we think about is, what are those things that we have stopped doing that's natural for us, that now, and why did we stop doing it? That's natural for us. There was a point when we had breastfeeding was natural, and then all of a sudden it was not modern. There was a time when we delivered our babies at home, and all of a sudden we needed to have a professional midwife. And then we weren't allowed to go to the hospital. So all these things really are studied from the point of view of what are those things that are natural, have been natural for us, and what stopped us from doing them, and now how do we get back to them? How do we take those habits, practices, and do them again to the degree that they're useful to us in today's life? Does that make sense? So that's why I wonder about assets and resiliency in those terms. You know, I didn't know that resiliency was what we had until I started to hang out with people at the university. What I knew is that we and truly did, my mother in particular, lived through unbelievable hard times. And when I would say to her anything about it, she did not call it being resilient. She said, I did what I had to do because I was alive, for God's sake. What you gonna do, sit around and not be alive? So that's where I would go with the asset and resiliency language, because I think it still keeps us in the canon of thinking about things from somebody else's point of view.
And Cyrus, what about how the systems, organizations, how does it respond? You shared with us how United Health Group was trying to support connections and some of the supports for living and thriving. What else would you add to that conversation? And what can institutions, if we're now practitioners in institutions, do to support or change some of that narrative?
Yep, thanks. And I was actually just going to go there. I think it chimes in nicely. So looking at this more from a national landscape, when I started the work at UnitedHealthCare, particularly around supporting people experiencing homelessness, addiction, recent release from incarceration, the models that people expected us to build were where we would come in and do it for the community. And I challenged that perspective because I understood from my own background, which I've shared with you, that there's a lot of great resources embedded in the communities in which we want to serve, and we are underutilizing those services. And those services, in some cases, because of silos, are not collectively working to the greatest potential. So what I started to do was to bring in to our organization subject matter experts in fields outside of the traditional, folks who were really good at things like housing, and then changing the perspective to look into the communities and find high fidelity partners who have been under-resourced and underappreciated, and bring our impact, our power, right, through funding and through data, analytics capabilities to those organizations to support them in doing their life's best work. So in other words, creating a network and helping to empower really great organizations, and then aligning the right people to them. So we were well integrated within the medical systems around the United States. We're contracted with all of the major health systems, I would say. But we haven't done a good job of doing the same type of coordination from a social standpoint, and even, I would say, a behavioral health standpoint. So thinking about creating a high-fidelity biopsychosocial approach, and that's exactly what we did. We started in Phoenix, Arizona. We brought on some housers who gave us access to roughly 100 units, and then connected to providers of social services, particularly institutions that embraced harm reduction models and had access to MAT, medication-assisted treatment, for folks that were struggling with addiction. Looked at incorporating access to food as well, and education systems, pivoted away from what was originally thought of employing folks and moved into helping people define purpose through their own story. So the power, again, of personal narrative. So it was an idea of supporting orchestration, acting as a backbone, or finding a really great backbone within the community, and then bringing in partners and facilitating the sharing of data and knowledge across institutions that may have been right across the street from each other, that were so complementary but never had the opportunity to communicate or share because of social barriers that we've put into place, whether that's related to data sharing or other things, and helping them with our resources, whether that was legal, finance, et cetera, to, again, achieve and broadly support that community.
Two more, you going to jump in, and then we'll have...
Yes. I actually wanted to say that it's really amazing what you've just said, because that's what Alina Health Systems, as well as the School of Public Health and the medical school and others who we've worked with in partnering, that's how they think about what we've done together. Who is the real backbone? Is it the Cultural Wellness Center, or is it Alina? And we've concluded that it's both of us. So Alina has cash and we have culture. And what we really have done is to make that the triple bottom line for the Backyard Initiative: cash, culture, and connections. And so we want to have a significant amount of each of those. And once again, I would say, not because we're here at the School of Public Health celebration, but it's the students who have also become a part of the human resources that we offer. We don't get money from the School of Public Health. We get people who are willing to learn, and people who are willing to do the mediocre kind of labor that we cannot hire someone to do. Does that make sense? So I think that what you're describing really fits very well with the model that we, Alina Health Systems, Cultural Wellness Center, and the School of Public Health, and once again, the School of Medicine have done.
Hi, thank you all again for sharing. And really quick, I want to say thank you, Katy, for your images. You showed some positive images of Black beings, and I think that's important. But I guess my question is, as a student, because I am a Master of Public Health Nutrition student, when I ask, what can I do, I'm often told, run for office or be class president or student body president, all these types of traditionally leadership roles that, to be quite honest, are not made for people who look like me, and I'm not sure I could get much work done in those positions due to other barriers. So I guess I'm wondering, what does it look like to empower people, not only like me, because I do have educational privilege, but people with less educational privilege, to view, if you will, healing as a source of advocacy and a source of doing something, right? Because I think it's a lot to ask people who are often marginalized to step up and sort of be a martyr in a system that wasn't built for us.
That is beautiful. Thank you for saying that out loud in this space. Thank you. Empowerment is you being your beautiful self, you following your purpose and your heart's calling, not aligning with someone else's idea of what success should be. And if what you want to do is political leadership, and that's what you're called to, then that's wonderful, and you need a whole community, and anyone who experiences structural discrimination needs a whole community around them to lift them up, to recognize that you're encountering systems that are not welcoming you, and in fact harming you and your people sometimes. So I think though that the idea of what can I do, and especially to students, I have learned so much about how to be my best self from my students, and what I would want to say to folks who, especially folks that experience disproportionate structural challenges, is figure out what it is that you are here on this earth to do, and gather around that purpose and do that thing. And it doesn't matter what anyone else thinks of that thing. That is your thing, and that's what you should do. And existence is resistance in some spaces, and being here in this privileged space is part of the work. Do what you were meant to do, and that is enough. It's your highest calling, but it's enough. You don't need to do what anyone else says you need to do.
So thank you all for being here. What a inspiring panel to listen to. I work at Hennepin Healthcare, downtown Minneapolis. I'm a nurse practitioner in the pediatric clinic. So these issues we talk about, being homeless and recently incarcerated every day, all the time. My question for Cyrus is, one of the things that I don't see incentivized is taking care of the people who need help with being homeless, because that's not as incentivized as like an MRI or being hospitalized. What are you doing at United Health Group to incentivize the healthcare system to take good care of those patients?
Yeah, it's a great question. So I want to start by just saying, one of the most important things to me, because I'll tell you that when I started this work, it was a lot like walking through mud. It's a Fortune 5 company. It's bottom line driven. It's run by folks in finance. And so when you talk about, when you ask the question, it was a challenging concept to gain traction on, as we talked about housing the homeless and supporting the most marginalized populations within, frankly, our entire portfolio. And one of the things that I did inside of that organization to make it real to the senior executive leadership team was to share the stories, the narratives of the people that we were serving, where they were coming from, where they currently were at, and where they likely were going to go, and connecting it to language that made sense to them. And it was brought up before that one of the things that I've spent time studying is business, and that was purposeful because I needed to be able to speak that language to make sense. I have a nursing background, but I needed to connect the dots from a finance perspective as well. And one of the important things that I was able to communicate to the executive leadership team was, one, look at the money that has been wasted by not taking clear and decisive action to support these folks. And two, if we don't do something now, if we don't create a meaningful intervention, we as an organization are going to suffer even more than we have in the past. That was the impetus for creating the incentive models that you had asked about. So then the question is, you had asked is, what are we doing to incentivize? So what we're doing is we're looking at shared savings models where these folks that we've targeted have a significant amount of previous medical spend, total cost of care, as we call it, looking at being able to say, look, if we can build a model with you in partnership that can make a collective impact for these folks, we can share some of that savings with you. And as a system, we all prosper together. So it's the shared savings models that I'd be happy to talk with you more about offline that have been particularly meaningful as we've continued to progress the work. And now, because we've been doing it for about 3 years, we have longitudinal data that's showing roughly 20 to 50% cost reductions for the people that we've supported by providing dignified housing with high fidelity, trauma-informed wraparound services, which to some folks is as important as some of the beautiful stories that have also come out of the work.
Well, we're clearly way out of time and over time, but I hope you will join me in thanking. We could go on all afternoon, but thank you to our panel.
Great. Thank you so much to our speakers for a really just awe-inspiring session. I think that one of the things that I really appreciate about it is that the speakers have called our field to a reckoning that we are having and that we need to have more of, but that you also kind of point us to sort of empowering steps we can take. One takeaway I had was the attention to language that each of you had, and our choice of words is really impactful, particularly as writers and speakers. And so I'd like to encourage us all to think carefully the next time we're using the royal we in papers or considering the labels such as participants and the unintended consequences of just following the mold. So thank you again to our speakers.